Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 418 of our pharmacotherapy series, which discusses neoplastic disorders and their treatment, general principles.
The next case reads, WPN, a 59-year-old woman, presents with shortness of breath, fatigue, anorexia, weight loss, and abdominal pain and distension that have worsened significantly during the previous 3 weeks. A CT scan of her abdomen shows a large mass surrounding the head of her pancreas with biopsy results that confirm pancreatic adenocarcinoma. The staging workup confirms the presence of distant metastases. Her husband states that she was previously an active person, but that she most recently has been unable to dress herself or participate in normal daily activities. He states that she spends most of the day in bed. My first question to you reads, will her activity level influence the type of treatment that she can receive? Cancer can have a profound effect on a patient's quality of life and his or her ability to tolerate appropriate therapy. Patients with malnutrition secondary to anorexia, mechanical obstruction, or pain may not tolerate some therapies because of significant physical debility. Performance status is a measure of functional capacity and reflects a patient's ability to ambulate, care for himself or herself, and carry out normal activities. For several cancers, poor pre-treatment performance status is associated with decreased ability to tolerate treatment, decreased tumor response to treatment, and worsened clinical outcome. In these cases, especially if the cancer is not known to respond well to treatment, a less aggressive treatment regimen may be recommended. For this reason, performance status is important to assess at the time of staging evaluation and periodically during treatment. Different scales, i.e., Karnofsky score, and Eastern Cooperative Oncology Group, abbreviated as ECOG, can be used to determine performance status. Because WPN has a poor performance status, ECOG grade 3, and may not tolerate chemotherapy well, her oncologist may recommend a less toxic treatment plan. Because other conditions, such as depression, could contribute to her symptoms, WPN should undergo comprehensive evaluation. The next case reads, TAJ, a 40-year-old man with no significant medical history, presents to his physician with complaints of abdominal pain, nausea and vomiting, weakness, and weight loss. On physical examination, he is noted to be slightly jaundiced. A CT scan of his abdomen reveals a mass present in the peripancreatic area that is suggestive of malignancy. Once diagnosed and staged, TAJ asks the surgeon how will this malignancy be treated? And what is the goal of therapy? What would your responses to these questions be? The choice of specific therapy and its goals depends not only on the histology and stage of the cancer, but also on the patient's predicted tolerance of the side effects of the various treatment options. The goal of therapy should always be to cure the patient when possible. The likelihood of cure is greater when the tumor burden is low, i.e., lower stage. When using therapy with curative intent is not possible, therapy becomes palliative in nature, with disease control and symptom management the priority. Goals of therapy should be balanced so that quantity and quality of life are both adequately considered. Cancer is predominantly treated with three modalities: surgery, radiation, and systemic therapy, including chemotherapy, targeted therapy, biologic response modifiers, etc. Systemic therapy is the primary treatment modality for hematologic malignancies. In most solid tumor malignancies, early-stage and localized disease is treated with either surgery or radiation therapy. Sometimes, combinations of modalities may be used to maximize the potential for cure or disease control, e.g., radiation given in combination with chemotherapy. For advanced disease, presence of metastases or recurrence after initial therapy, solid tumor malignancies are usually treated with systemic therapy as the primary treatment modality. TAJ's treatment will be dependent on tumor histology, stage, and expected prognosis. If TAJ has potentially curable disease, he should be treated with curative intent therapy. Whereas if TAJ has advanced disease that denotes a poor prognosis, he should be treated with palliative therapy. Surgery is an important treatment option for patients diagnosed with certain solid tumors. With the recent advances in surgical techniques, e.g., minimally invasive procedures, and improved understanding of patterns of tumor growth and spread, successful resections are possible for an increasing number of patients. Surgery may be used as preventive therapy, e.g., removal of colonic polyps or cervical dysplasia, or diagnostic treatment, or staging of some cancers. Surgery can be used to manage both localized and advanced tumors. When surgery provides curative therapy for a localized tumor, the surgeon removes the tumor plus a margin of normal tissue surrounding the tumor. For extensive, localized tumors that cannot be completely removed, selected patients may undergo cytoreductive surgery to resect the tumor partially in an attempt to improve the likelihood that subsequent chemotherapy or radiation therapy may successfully kill the tumor. Patients with metastatic disease may have palliative surgery to relieve pain or improve functional abnormalities caused by the advanced tumor, e.g., gastrointestinal obstruction. Palliative surgery may improve quality of life without prolonging survival. Radiation may be administered as either curative or palliative therapy for solid tumors. Radiation is administered in varying doses depending on the type of tissue, e.g., bone, lung, breast, liver, or brain, being treated and the intent of therapy, palliative or curative. A limit exists to the total amount of radiation that can be delivered to the area being treated dependent on the type of tissue. Damaging effects of radiation on the normal tissues that surround the tumor can be dramatic, and may be exacerbated if given concomitantly with chemotherapy. Chemotherapy that follows completion of radiation therapy can produce radiation recall of local toxicity that manifests as skin redness, swelling, and peeling at the radiation site. Not all cancers are sensitive to radiation, so this modality has limited application in these cases. For radiation-sensitive tumors, potential advantages exist over surgery. For instance, Radiation therapy may encompass a wider area around the tumor and treat tumors in regions of the body where surgery cannot safely be performed. Radiation therapy also can be used when surgery could result in considerable disability or disfigurement. Patients may receive radiation therapy to multiple sites simultaneously. Multiple methods are used to administer radiation to tumors. External beam radiotherapy and brachytherapy are two types that are commonly used. Newer radiation therapy techniques, including intraoperative radiation, hyperfractionated radiation, stereotactic radiosurgery, intensity-modulated radiation therapy, charged particle, that is proton, radiation therapy, and computerized three-dimensional conformal treatment planning, may reduce associated toxicities, enhance tumor responsiveness, and improve the clinical usefulness of radiation. We will briefly look at systemic therapy. Not all cancers can be treated by surgery or radiation therapy. Patients may present with widespread metastatic disease at diagnosis or recur following primary treatment with surgery or radiation. Patients may also have residual tumor following initial surgery or radiation, requiring additional treatment. In these circumstances, systemic treatments including chemotherapy, targeted therapy, endocrine therapy, and biologic response modifiers generally offer the only hope of controlling disease. Let's now consider chemotherapy. The National Cancer Institute defines chemotherapy as drugs that treat cancer cells. For the purposes of this chapter, chemotherapy will be defined as cytotoxic therapy that is directed toward rapidly dividing cells. Chemotherapy kills cancer cells by damaging DNA, interfering with DNA synthesis, or inhibiting cell division. Chemotherapy agents are classified by their effect on the cell cycle or mechanism of action. Agents that affect a specific phase of the cell cycle are referred to as phase-specific agents or schedule-dependent agents. In contrast, agents that affect any phase of the cell cycle are referred to as phase non-specific agents or dose-dependent agents. We will now briefly look at factors that influence response to chemotherapy. Regarding cell kill, studies using rodent animal models during the 1960s demonstrated that the number of tumor cells killed by chemotherapy is proportional to the dose when the growth fraction is 100%, i.e., all cells are dividing, and the tumor cells are sensitive to the agent. For example, if a dose of chemotherapy reduces the tumor burden from 10^10 to 10^8 cells, the same dose administered when only 10^7 cells are present should reduce the tumor burden to 10^5 cells. This theory has become known as the cell kill or log kill hypothesis. In the clinical setting, tumor cells do not always decrease predictably with each successive course of chemotherapy. This is because the growth fraction of human tumors is not 100% and the cell population is heterogeneous, with some cells that are resistant to chemotherapy. Dose intensity is defined as the chemotherapy dose per unit time during which treatment is given, e.g., milligrams per meter squared per week. Drug resistance might be overcome by increasing the dose of chemotherapy. Evidence suggests that reducing a dose can cause treatment failure in patients with chemotherapy-sensitive tumors who are having their first chemotherapy treatment. A direct relationship between dose intensity and response rate also has been reported in several human tumors, including breast cancer, lymphomas, ovarian cancer, and small cell lung cancer. However, dose-intensive therapy has not consistently improved the overall cure rate of most solid tumors. The dose intensity for most chemotherapy regimens is limited by the major dose-related toxicity, bone marrow suppression. To minimize this toxicity and administer higher doses, patients may receive hematopoietic growth factors, autologous stem cell transplantation, or altered schedules of drug delivery. We will now briefly look at schedule dependency. Chemotherapy is administered in cycles, e.g., every 2, 3, or 4 weeks, with recovery periods between cycles. A typical course of chemotherapy usually consists of several cycles. The interval of time between cycles depends on the type of cancer and the drugs being used. The optimal schedule is also influenced by the pharmacokinetics of the agent. For example, phase-specific agents exert their cytotoxic effects only when the cell is in a particular phase of the cell cycle. If a phase-specific agent with a short half-life is administered by intravenous bolus, a significant number of tumor cells will not be in the vulnerable phase of the cell cycle during exposure to the agent. Comparatively, the same agent administered by frequent intravenous bolus or continuous infusion could expose more cells to the agent during the vulnerable phase.
So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 419.